thank you. So we go to our next topic, different modalities for macular holes of different sizes and in retinal detachment. So this is the history was first described by Knapp in 1869, and modern concept and classification we follow mostly by gas, and the prevalence varies from 3.3% outside to 1.7% in India, and bilateral case can happen in 11.1% of these cases. So diagnosis we do by clinically slit lamp biomicroscopy, and now mostly OCT to corroborate. And the classification of the macular hole, I'm not going to too much details. Basically stage 0, 1A, 1B, stage 2, 3 and 4. And this is a classification of commonly used full thickness macular hole. So this is stage 2 is small hole, a small or medium FTMH, full thickness macular hole, vitreomacular traction. Stage 3 is large hole, medium or large full thickness macular hole with vitreomacular traction. Stage 4, full thickness macular hole with PVD. This is small, medium or large full thickness macular hole without vitreomacular traction, where PVD is already there. So this is the photos, impending macular hole and prognostic indicators of macular hole. So usually the most important indicator, it is said that the size of macular hole and the minimum hole diameter is the most important prognostic indicator. Then there are also reports about duration and morphology and thickness of foveal photoreceptor layers, then defect in interdigitation zone, external limiting membrane or ellipsoid zone, and then also there are hole forming factors, then macular hole index, then tractional hole index. Also some computerized aerial designing software is there. We use different dyes like triamcinolone, indocyanine green and trypan blue. Nowadays we all of us mostly use brilliant blue dye. So there are a few videos which we can see and then discuss. This is the old time 23 gauge surgeries. There is a post retinal detachment surgery with silicone oil, then we took out the oil. The age of the child was 9 years old, and there's a one-eyed child. She was operated for a giant retinal tear. We can see the laser marks there, and it's a pretty big size hole. So but the posterior pole was little bit of boggy, and we can see the attachment is also quite tenacious, unlike the normal ILM. So this is the papillomacular bundle. ILM is still there, and we put PFCL to stabilize, because that area we don't want any iatrogenic trauma, and so under the PFCL is much easier to kill that ILM. And then we take out the PFCL and normal fluid exchange with gas. This is a patient of inverse flap technique, both eyes pseudophakic 660 and 66 vision. You can see there's a stage 4 macular hole, and this is 25 gauge surgery we did. So after induction of the PVD, we stained with brilliant blue dye and picked up the temporal ILM. And we just trimmed it and we did not try to put it inside. Basically, we did a fluid exchange slightly with some patience, so we can see that it will automatically be all around that hole only. And we should be careful that that flap should not come inside that extrusion cannula, so all of your trouble is gone then. So that is the result. And this is one of the case which is a bad traumatic macular hole. You can see the papillomacular bundle retina is non-existent like that. And here also phenyl I used because not much ILM is also there, so I could not peel also from the inferior part and inside the arcade bad scar. And managed to put that ILM flaps. And it trimmed the flap, and then we did the fluid exchange so that the flap goes over to the hole, covering the hole. You don't have to put it inside, basically just covering is enough. And see, nicely healed the hole. And we can see it is closed. The outer tissue was there and the vision improved also. And this is one of the nowadays, you can say, less of the trouble we are taking. The decreased our timings for macular surgery nowadays with this lab. So we just take out the temporal thing, and so this is the before and after surgery. So this is the last one with the detachment with macular hole surgery. And of course, I usually peels with the PFCL, another PFCL, but lots of people peels in detached retina also. And there is a retinotomy I did, and then a few of the holes are already there, the bricks. Stain it, and under PFCL I think it's much more easier to peel. Not a problem at all. In fact, nowadays under PFCL also sometimes we can put the flap back inside the hole. The result is equally good. So that was the final OCT came. Thank you.